Dr. Stuart Schnitt is the Chief of the Division of Cancer Pathology at Beth Israel Deaconess Medical Center, Chief of Oncologic Pathology at Dana-Farber Cancer Institute, and a Professor of Pathology at Harvard Medical School in Boston, Massachusetts. Please join me in welcoming Dr. Schnitt.
Thanks very much, Rachel. What I'd like to do is to amplify primarily on Ann's talk, but also talk a little bit more about AI in general. I truly believe, as you've just heard from the prior two speakers, that with regard to AI in breast pathology and in general in diagnostic pathology, the future is really here. These are my disclosures. So this kind of summarizes what you've heard from the last two speakers about how AI can help in our daily practice. Well, you've heard that it can improve workflow and reduce turnaround time. It can level the playing field and increase accuracy and reduce inter-observer variability. It can provide the opportunity for second reads before final sign-out to ensure clinically significant lesions have not been missed, thereby providing a QA function. And to me, some of the most interesting things is that it can do things we don't like doing, are not very good at doing, or are time-consuming, like quantitating things. I don't know about you. I don't like quantitating anything. So if I have a machine to do it, that's fine with me. And to me, the most intriguing thing about AI is potentially having the ability to do things that we can't do and that we'll never be able to do visually, and identify things with regard to prognosis, prediction, et cetera. Anne talked about this study. I'll talk about it a little more, the Ibex Breast algorithm. This was based on a fully supervised multi-layered convolutional neural network system and specifically designed to classify and analyze whole slide images of breast biopsies. It was trained on more than 2 million labeled image patches on more than 2,000 slides from multiple labs that were manually annotated by more than 20 senior pathologists, and it identifies more than 50 different lesions and pathologic features of invasive breast cancer and DCIS and in situ breast cancers and benign breast lesions. Here's an example of a case of DCIS, which you can see on the left, associated with invasive cancer on the lower right. And again, as you've seen in the prior presentations, if you hit the invasive cancer heat map, you get a nice red area in the area of invasive cancer. If you press the the in situ carcinoma heat map, it nicely recognizes the in situ carcinoma, excluding the invasive cancer. Amplifying on a slide that Anne showed, this is even more studies than Anne showed, with more than 3,700 cases from 7 different sites that have used the Ibex Breast algorithm. And you can see again, the AUCs for invasive carcinoma and DCIS are on the order of 0.98 to 0.99 in every one of these studies. More recently, Elena Provenzano presented these data at the 2025 European Congress of Pathology meeting. This provides the AI accuracy results on 6,200 cases that were studied at various institutions in the National Health Service in the UK. And again, you can see almost perfection in identifying cancer, invasive cancer, and DCIS. So combined between the prior studies that I showed and this study, this is about 10,000 cases that have looked at this algorithm worldwide and have basically come up with the same results, that there were AUCs on the order of 0.98 to 0.99 for invasive cancer and DCIS. And I don't think you can get much better than that. In addition, the study that Elena presented demonstrated that, particularly for benign breast biopsies, the use of the algorithm reduced the need for immunohistochemistry in a substantial number of cases. At 2 different sites on the left, at one of the sites, it reduced it by 23%, at the other site by about 76%. In addition, in the study, in another study that was presented at the ECP meeting last September, Manuela Wexler presented data showing that the time needed for reviewing all kinds of specimens was reduced with AI, and you can see that is in black, and without AI in orange. And the proportional reduction in the time for review is about 50% for benign lesions, 40% for DCIS, and about 40% for invasive cancer. So a total reduction in the time for review in all of these cases of about 44%. And believe me, I could use 44% of my time back to do other things. Now, one could argue, well, great. The algorithm can identify cancers in DCIS. I can do that visually. Why do I need an algorithm to do that? And you could argue, well, maybe you don't. But where I think AI can really be of added value even more is in cases and situations that we as pathologists find problematic or difficult. So, for example, what about distinguishing invasive ductal from invasive lobular carcinomas or identifying small foci of invasion? How does this algorithm do in those settings? Well, is distinguishing ductal from lobular carcinomas really a problem? Well, I never thought it used to be until I saw data from these two clinical trials. These are two large randomized clinical trials where the initial diagnosis of cancer was made at an outside institution and then subjected to central pathology review. And I was shocked to see that in both of these trials, the agreement with the diagnosis of invasive lobular was only 60% in one study and 66% in another study. So clearly there are more objective ways needed to classify ductal versus lobular carcinomas. So how can artificial intelligence algorithms help standardize this diagnosis? Well, in the Ibex algorithm that was first published in 2022, you can see that for distinguishing ductal from lobular cancers in 153 cases, the AUC was 0.973. Using this same algorithm in another study, a group from Hartford Hospital had an AUC of 0.94. So this algorithm is very good at distinguishing lobular carcinomas from ductal carcinomas. Here's an example of a core needle biopsy on the left. And if you press the invasive cancer heat map, you can see the foci of invasive cancer in red. And further, if you press the ILC versus IDC heat map, ILC shows up in blue. And if you go to higher power on H&E, you can see this is clearly an invasive lobular carcinoma. So this algorithm is very good at distinguishing lobular from ductal cancers. Now, what about identifying small foci of invasive cancer? We're all terrified of looking at cases of DCIS with a lot of lobular involvement and stromal inflammation and desmoplasia and trying to find areas of microinvasion. How does this algorithm do in that setting? Well, we presented a study a couple of years ago at this meeting where we looked at 147 slides with DCIS from Brigham and Women's Hospital and Champalamo Foundation in Portugal. 85 of these had microinvasion and 62 had DCIS only. And I can tell you that the DCIS only slides were from cases that also had microinvasion on other slides. So these slides essentially served as their own control. And also, it's important to note that these cases were biased toward very difficult cases. I picked the cases, and I was looking at these DCIS cases and saying, the algorithm will never find the microinvasion in this with all this lobular involvement and inflammation and stromal desmoplasia, et cetera. The H&E slides were scanned on different scanners at two different institutions, and the digitized slides were evaluated using the algorithm, which you need to note was trained to detect frankly invasive cancers. This was not trained to detect tiny foci of invasion. However, the algorithm incredibly did very well in detecting microinvasive foci. It detected foci of microinvasion with a medium or high likelihood in 83.5% of the cases. In addition, there were 14 additional cases where the microinvasion was considered by the algorithm to be of low likelihood, but there were regions of interest highlighted by the algorithm that directed the pathologist to look at them and said, basically, just check this out and make sure that this isn't invasive. And in fact, after review by the pathologist, the algorithm had correctly highlighted the microinvasive foci in all but 2 cases. So in total, foci of microinvasion were detected by the algorithm in 98% of the cases. So here's an example on the left of a case of DCIS with microinvasion. You can see the DCIS on the left, the microinvasive foci on the right, and the invasive cancer heat map, when applied to this, highlighted the areas of microinvasion. Here's a more subtle case of DCIS where the focus highlighted in red is shown over here, and there was a little focus of microinvasion there that could easily have been missed. In addition, the algorithm identified microinvasive foci in 5 slides that were missed by pathologists and categorized by the pathologist as DCIS only, and these are the oops cases. So here's an example of one of these. This case was a nightmare case that had extensive lobular involvement by DCIS with extensive stromal chronic inflammation. And it's really, really hard to find whether or not there are foci of microinvasion here. But when the invasive cancer algorithm was applied, this little area was shown in red, and you can see at high power in the circled area, there's a little focus of microinvasive cancer. So following up on that first study, we did another study that was presented at the ECP meeting last year, where we looked at the AI tool to be able to identify microinvasion in a larger number of cases, and also included T1A invasive cancers. And the study endpoints were to assess the accuracy of pathologists supported by AI in identifying small foci of invasive cancer associated with DCIS, either microinvasion or T1A, and evaluate the pathologist's review time without and with AI. So in this study, there were 200 digitized H&E slides of breast biopsies from 2 different centers in the US and Europe. They were scanned on different scanners, and just as in the prior study, these cases were biased toward difficult cases with an overrepresentation of DCIS with potentially confounding features like stromal chronic inflammation and lobular involvement. The way the study worked is the 200 cases were divided among 4 readers. Readers 1 or 2 looked at cases 1 to 100. Readers 3 and 4 looked at cases 101 to 200. They looked at them without AI visually under the microscope. And after a 2-week period of washout and with AI training, they reread these cases with AI augmentation. And basically what you see from these bar graphs is that whether you look at microinvasion and T1A together or you look at them separately, that the agreement with the ground truth for these pathologists was greater with AI in red than without AI in blue. So it's clear that the AI helped the pathologists identify these small foci of invasive carcinoma. Furthermore, the use of AI in the bar graphs in red reduced the time needed for review of these cases. Overall, there was about 11% reduction in time. For the slides with DCIS, only about a 30% reduction in review time, and for the microinvasive cases, about a 10% reduction in the review time. So we concluded from this study that the use of the Ibex AI algorithm resulted in significantly improved detection of microinvasion and T1A breast cancer in association with DCIS, and significantly reduced the time required for slide evaluation of the microinvasive and T1A cases. So in summary, I think based on what I've told you so far, we can conclude that the Ibex Breast algorithm is highly accurate for the diagnosis of benign lesions, DCIS, and invasive cancer, even for the identification of the smallest foci of invasive cancer. It reduces the need for immunohistochemistry, as you heard with the prostate, and reduces the time required for review. So what else can the Ibex Breast algorithm do for cases of breast cancer? Well, either now or in the short term, it can prioritize cases. So as you saw with prostate, you can come in the morning and have your cases sort of rank ordered by the likelihood of invasive cancer and look at the ones that are more likely to have invasive cancer first. It can evaluate lymph nodes. Now, I always tell my residents and fellows that if I never have to look at a lymph node for metastases under the microscope, that would be fine with me. Let an algorithm do it. They're not going to complain. The algorithm's not going to complain about how difficult that is. The algorithm can identify lymphovascular invasion, quantitate TILs. It can result in pre-ordering of IHC. For example, if the algorithm detects cancer in a lesion, in a biopsy, then it can pre-order the ER/PR and HER2 assays, and you can improve the turnaround time with that. As you just heard from Anne, it can help score ER/PR, HER2, and Ki-67, and coming soon, Nottingham grading as well. So, to conclude this session, I think we've acknowledged that the use of AI algorithms is likely to transform the practice of surgical pathology. There are many positives to this. It can reduce the overall workload, shorten turnaround time, provide us with more consistent and accurate diagnoses, provide a QA function when it's used as a second read, and do things we don't like doing, are not very good at doing, or are time consuming. And as was alluded to before, AI is not going to replace pathologists. AI is going to become an adjunct, just like enzyme histochemistry was in the 1950s and early 60s, EM was in the 60s, immunohistochemistry was starting in the 1980s, molecular pathology is today. These are all adjuncts, and this is going to be an adjunct as well. But it may well be that pathologists who use AI may replace pathologists who don't use AI. But in the end, pathologists still should and need to have the final word. And available data from multiple studies, not only in pathology, but in radiology studies that have used AI, suggest that the combination of the pathologist or radiologist plus AI is better than either alone. And again, as was alluded to before, maybe a better term for AI is augmented intelligence rather than artificial intelligence. And with that, I will end and thank you for your attention.